etc., so on and so forth. So I will be touching on this topic on the following headlines. So essentially, first half we'll talk about acute congestive heart failure and where and why, when and how we use diuretics. We will briefly touch the physiological abnormalities, see what is the rationale behind the use of diuretics in both of these conditions, risk benefits, and the evidence in support or against the use of the diuretics in both these pathological situations. Now, acute congestive heart failure is a fairly common problem, particularly when we are talking about a coronary care unit or even a intensive care unit which deals with a high degree of medical cases. Now, it's one of the most common medical emergencies that we come across, and in the United States alone, there are about 650,000 cases, new cases, which are diagnosed and get admitted into the intensive care units or the high dependency units across the United States. This amounts to about 1 million or 10 lakh hospital admissions every year into the acute care setting, either in the high dependency, emergency, or into the intensive care units. Now, the presentation of acute acute heart failure could be either a new onset, sudden onset of an acute coronary syndrome, which precipitates and presents itself as a congestive heart failure, or it could be progressive decompensation of a chronic heart failure, either due to a precipitating cause or just downhill progression of the pre-existing illness. Now, though this is a common condition as we have seen and a fairly expensive condition to treat, we also have a problem here that the quality of data that we have today or the guidelines that have been put out by the American Heart Association or any other equivalent body is based on very, very thin level of evidence. Now, briefly, the pathophysiological mechanisms. As you can see on this figure, what we see at the tip of the iceberg is only a tip of the iceberg in terms of the clinical signs and symptoms, because underneath these things there are a variety of physiological and pathological changes which take place before the patient presents to us with the typical clinical features that we see with congestive heart failure. So as we are all aware, it is either a systolic or a diastolic failure. I would like to emphasize that every other patient who comes to you with a congestive heart failure doesn't necessarily have to have systolic dysfunction, because we are now recognizing that diastolic heart failure is more and more an important problem that we face in the intensive care setting. So any form of abnormal LV function, be it systolic, diastolic, or both, results in a backward pressure resulting in elevated diastolic pressure, LVDP, that's the left ventricular diastolic pressure, which in turn causes back pressure, causing pulmonary venous congestion, right heart back pressure, and subsequently causes elevation of the elevation of the pressures in the venous system. So that is why typically we get the presentation that we see wherein we have got predominantly features in the lung, there is an elevated JVP, there is pedal edema, so on and so forth. Now, this entire thing is mediated by a very complex neurohumoral mechanism, which actually is constantly active because of the poor left ventricular systolic or diastolic function, and mediated by one decrease in relatively low intravascular volume status as it is identified by the body, and of course the persistent back pressure which causes this neurohumoral activation to take place. So if you can see, it's a very complex thing involving a variety of chemical and biochemical reactions inside the body, and the end result of it is what we call as congestive heart failure or congestion in various aspects of the tissue, which could be lung, then back pressure into the venous system, and also tissue interstitial edema. Now, this in turn further causes a vicious cycle to be set up, and there is, because of the congestion, there is further depression of the heart function, causing more volume overload, so on and so forth. And in about 30 to 40% of patients, we do end up with various degrees of renal insufficiency. So the end result of this complex neurohumoral mechanism is retention of salt in water, which presents to you as signs of congestive heart failure. So commonly we come across the symptoms that we come across is, as you're all aware, symptoms such as dyspnea, maybe exertional orthopnea, progressive dyspnea, so on and so forth. Many a time they may even come to you with flash pulmonary edema, requiring to go on to various forms of supportive modalities. On examination, you find that the patient has got bilateral crepitations. He may be frothing pulmonary edema when he comes. He may be required to be intubated, having very high AA gradient, high peak pressures initially. And of course, evidence of right heart failure as well in the form of a hepatomegaly and pedal edema if the problem has been relatively long-standing. Now, given time, as I said, 30 to 40% of these patients either acutely or over a period of time develop various forms of renal insufficiency, and that further triggers this process of accumulation of this fluid and salt, and therefore decongestive therapy, as we say, has been the mainstay of therapy for treatment of various forms of congestive heart failure, be it acute or decompensated heart failure. Now, when I say decongestive heart failure, of course, there are different ways by which we go about this, and the time-tested modality has been the use of diuretics over the last 3 to 4 decades. Of course, there are other newer modalities which we use if there is failure of diuretic therapy, such as fluid removal by dialysis or other forms of extracorporeal methods. Now, the use of loop diuretics has been one of the most common forms of diuretics that we use. In addition to, of course, we do use thiazides more as an adjuvant and spironolactone as well for its other effects rather than more as a diuretic, because both of these are weak diuretics. So the use of this loop diuretic has both its positive and negative effects. The positive effect, of course, being that because it causes a negative sodium and water balance, it does have has a favorable impact on the cardiac filling pressures, wherein the high filling pressures become more manageable, and therefore you result in the various, there is some degree of reversal of the various forms of myocardial dysfunction that we see. There is also an action of the loop diuretics on the prostaglandin system, which therefore causes vascular smooth muscle relaxation involving both the vascular, the arterial and the venous side, predominantly the venous side, and this has an effect on the renal and pulmonary vasculature. On the flip side of this, of course, we have got inhibition of the macula densa, and because of the negative sodium and water balance, there is a state of relative intravascular volume depletion that happens, and consequent to this, we end up getting a significantly activated and a persistent activated renin-angiotensin mechanism, which causes secondary hyperaldosteronism and further delivery of sodium into the distal tubules, which has been reduced because of the loop diuretics that we had used, and that is where we develop what is called as diuretic resistance. Of course, there are different ways to treat this problem, but I won't go into the detail of this. The only idea of the last two slides was to emphasize the degree of changes and the complex mechanisms that are there behind the simplistic thing of what we say as congestive heart failure. Now, there have been a number of studies and particularly retrospective analysis over the last few decades, last 10 to 20 years, which have said that there has been increased risk of acute kidney injury with the use of diuresis and various different types of dosing and methods of administration of furosemide. Now, some of this data is fairly robust in terms of the number, because there have been retrospective studies done on large registries like the ADHERE registry. However, because of its retrospective data and its retrospective nature, the quality of this data has been very, very poor, and therefore interpreting this data and translating that into what we would consider as good quality evidence is probably not appropriate. So there was a relatively large randomized trial which was conducted, published in the NEJM in 2011. It was called the DOSC study, wherein they compared two diuretic strategies using loop diuretics, that is furosemide, in a 2 into 2 factorial model. So essentially, when we say 2 into 2 factorial model, it means there are two different aspects of the interventions which are looked into. So what they looked into here was comparing low dose versus high dose furosemide, and also comparing furosemide to be which is administered as bolus doses plus a continuous infusion. So basically, in the same study, they have actually tried to answer two different questions, and surprisingly or unsurprisingly, we found that there was no difference in terms of mortality, no difference in terms of the risk of acute kidney injury, whether the drug was used in a higher dose or a lower dose, or whether the drug was used as a continuous infusion or a bolus infusion. However, there are theoretical advantages of using it as a continuous infusion because of the fact that some of the meta-analysis have actually shown that there is possibly a higher incidence of hypotension and hypokalemia with the use of these drugs as bolus doses. So even if you see in this graph, there is a slight dispersion of the two curves, which means that there may be a trend towards a better outcome in terms of symptoms when you use a high dose strategy, and so also a slightly better tolerance of the patient to using furosemide when it is used as a continuous infusion. In fact, in a subgroup analysis, they found that subjectively the patients who received high dose furosemide actually did feel a little better, but because it was a subjective assessment, it will be open to various questions. Now, following this, there have been a couple of meta-analyses which were performed, and one of them was this one by Yu and et al., wherein they actually collected studies which compared continuous versus bolus doses, and found that overall, over a period of time, there was no difference in outcomes using either the continuous modality of continuous infusion of furosemide or using it as a bolus dose when you are treating patients who present to you with acute decompensated heart failure. The only difference in a subgroup analysis, what they noticed was expectedly the urine output was better and more in the first 48 hours, but given time, if you look at the last forest plot, you find that over a period of about 72 hours, the urine output actually equated in both the groups. So essentially, whether you use it as a continuous infusion or as a bolus dose, if you look at the studies, there is no particular data to actually support that one is better than the other, and also to say that high dose furosemide high doses of furosemide per day is probably relatively safe if you have to really use it in a patient who comes to you very, very sick. Now, there's another thing that you should remember is that when we say that when we are using diuretics for heart failure, it does result in acute kidney injury and is known to cause a higher incidence of acute kidney injury. There could be other causes also for which acute kidney injury can happen in this kind of a setting. So it's not appropriate to blame the drug always, and you should always look for other causes, like the persistently low poor LV function itself may be a cause which results in what we sometimes call as cardiorenal syndrome. There could be an associated renal artery stenosis because of atherosclerosis, pre-existing renal disease secondary to diabetes, hypertension, or any other intercurrent illness like sepsis. So in conclusion, diuretics have been the mainstay of therapy for acute congestive heart failure, and in the absence of any other modality is probably still one of the best methods of decongesting the body. No evidence to support that decongestion changes mortality, and this is true for not only diuretics but also for use of ultrafiltration or other forms of extracorporeal techniques. So when we use diuretics, we are only giving the patient a symptomatic benefit and buying time, but not really changing the pathological process which is ongoing. Decreased urine output during diuresis could suggest another problem, so don't blame the diuretics always. Look for other causes before you make diuretic as the cause for that. Decreasing output to diuresis is not a good sign. So if somebody who's been responding well to diuretics suddenly stops responding, then that is not a good sign. It's not because of the diuretics, but it's probably indicating that the disease itself has progressed and the kidney injury itself has worsened. And the role for immediate symptomatic management in respiratory failure, it has a role for immediate symptomatic relief in a patient who presents to you with respiratory failure. Now, moving on to the second phase of this talk which is diuretics in acute kidney injury. Now, this is the new definition of acute kidney injury as we call the Rifle criteria. This is just for your information. Of course, it's present in all the journals, all the textbooks, and that is what we currently use as the modality of measuring acute kidney injury, which was erstwhile called as acute renal failure or various other names that we used previously. The physiological rationale for the use of diuretics in acute kidney injury is manifold. One is to decrease the tubular absorption of sodium and therefore offer is what is called as rest to the kidney. That is what the common algorithm has been, that we would like to rest the kidney by actually blocking the sodium potassium pump and therefore decreasing the sodium absorption at the Henel's loop. And it is particularly true for the juxtamedullary nephrons, which are generally very susceptible to ischemia. The use of diuretics in AKI, the rationale is to increase the urine output, achieve adequate fluid balance, hasten the renal recovery, and prevent progression to chronic kidney disease. So this has been the theoretical use for which we use we use the diuretics. But on the other hand, the flip side, we clinically actually we find that because of the persistently higher sodium delivery to the distal tubules, there is actually higher metabolism in the deeper parts of the juxtamedullary junction or in the deeper parts of the nephrons in the medulla, and therefore actually the advantage where oxygen sparing takes place is actually wrong. And in fact, there may be a higher oxygen demand for of the kidney, which actually further progresses or increases the risk of acute kidney injury. And because of a relative intravascular depleted state, there is persistent activation of the renin-angiotensin system and the sympathetic system. And clinically also, we don't get the same result that we thought of was a theoretical advantage of using furosemide. So going to some of the clinical studies, evidence for diuretics in AKI, Swad et al. Was one of them who showed that in a patient who's in the perioperative cardiac surgical period, they found that there was better urine output in patients who are on whom better urine output and decreased renal oxygen consumption by the kidney in patients on whom furosemide was used as an infusion for the first 48 hours. However, within about 2 to 4 years after that, another study actually on similar set of patients, larger study by Redforce et al. Quashed this theory. And there have been numerous prospective multicentric cohort studies, and the largest of them published most recently in 2013 in the CCM, was from Finnish ICUs across about 15 ICUs across the whole country of Finland, where they found that diuretic use was one of the risk factors for acute kidney injury in the intensive care setting. Now, whether diuretic itself is the cause or whether diuretics were incidentally used in these patients is a little bit difficult to say, particularly because these are, as I said, not randomized trials. However, surprisingly, in one of the studies of similar nature, they actually found that post-hemodialysis, renal recovery was not impaired if hemodialysis was used, though it was associated with a higher risk of hypotension during dialysis because of the depleted intravascular volume. Now, in a meta-analysis published in the BMJ, wherein they pooled many studies and only localized about 9 studies of reasonable quality, they found that use of furosemide was not associated with any protective impact on either preventing acute kidney injury or in the treatment of acute kidney injury, as you can see in this forest plot. Similarly, they also found that there was no change in the requirement of renal replacement therapy other than the fact that the number of sittings of renal replacement therapy was possibly lesser because of better fluid management. However, there was no improvement in terms of earlier renal recovery or any other such modality with the use of diuretics. Now, diuretics in acute kidney injury are specifically used in certain select subgroups, and of course, which is more based on physiological rationale and theoretical advantages, but not really proven in robust studies. One of them is what we call as forced alkaline diuresis, wherein the proposed mechanism is to prevent renal vasoconstriction, cause suppression of the renin-angiotensin mechanism, inhibit the renal vasoconstriction, and also prevent tubular obstruction. Now, these are specifically indicated in patients with toxicological problems like salicylate overdose and tubular toxins such as contrast-induced nephropathy or pigment nephropathy, as seen in rhabdomyolysis or any other pigment nephropathies. Now, contrast-induced nephropathy is a totally different kettle of fish, so I would not go much into the details of this. As we all know, good hydration has been the standard of care for the last 15 to 20 years, time and again proven with many, many studies. Whether furosemide adds value to that is a questionable thing. There has been studies which have shown in favor and against as well. As you can see, the Canadian study showed that there was an increased risk of AKI. However, another study called the Mythos study published in the Cardiovascular Journal showed that in patients who were put on a furosemide infusion along with the gentle hydration, they found that the risk of causing contrast-induced nephropathy were lower in patients who are documented to have chronic kidney disease. Compartmental syndrome causes rhabdomyolysis, and diuretics are are suggested by various authors. Mannitol is the preferred way to go because of its theoretical advantage of causing what we call as flushing the tubules of the pigments. Loop diuretics can also be used and are suggested by some authors, but there is a risk of causing alkalinization, acidification actually in the tubular lumen, and therefore it may be difficult to actually, it may actually cause further precipitation of the tubules. The other places where we can use diuretics is to achieve fluid balance, specifically in the presence of acute lung injury, and this was proven that excessive fluid in the body as a part of resuscitation or any other modality in the FACT study as well as in a multicentric Italian study showed that lower the fluid, use of diuretics actually resulted in better outcomes. So to get your fluid balance right, use of diuretics could still be advocated in patients in the intensive care unit, whether they are having acute kidney injury or not. And also prevention of progression from acute kidney injury to chronic kidney disease. There are many interventions which have been used. One of the newer things which have been now tested in animal studies and found to be favorable is the use of spironolactone. Though it's a weak diuretic, it's got some theoretical advantages and proposed benefits and may prevent progression of an acute kidney injury to chronic problems, but this is again still in experimental studies. And non-traditional diuretics in AKI have also been tried out, and one of them is nesiritide, which has been used as an infusion in perioperative periods in a couple of studies and found to have no benefit. And so what is the reason? Can I just take half a minute extra? So what is the reason of the failure of diuretics? Essentially, it's a good rationale. Theoretically, it sounds very nice. But in clinical practice, we don't find the renal protection strategy that we get that is subjected or that is proposed in the theoretical side of things. Now, the reason for this is acute kidney injury is not a single problem. It is a complex problem which is a multifactorial situation and also controlled by more than one process, as we saw in the last few slides. And diuretics can only increase the urine output at times, but particularly have no effect on other protective strategies of the kidney or other injuries that the kidney undergoes during this situation. And there is no role for no role if there is a volume depletion of the kidney as well. Last slide. So in summary, there is no role for routine diuretics in acute kidney injury because the previously believed theory that it protects the kidney is not proven. It may be detrimental actually to use diuretics, particularly when you're talking about patients who are in the early phase of their critical illness, wherein they are generally volume depleted. It can be considered in acute kidney injury if there is evidence of fluid overload, especially in the setting of acute lung injury, because your aim there is to actually protect the lung. Specific situations of where diuretics may have a role is, as we already discussed, is in forced alkaline diuresis in patients who have toxin or pigment-induced nephropathy. Patients who present to you with very severe acute lung injury and are responsive to diuretics, you could use diuretics whatever may be the intravascular volume status. Loop diuretics are still the preferred choice at the moment for AKI and management of AKI, and particularly, and when I say AKI, management of the fluid management of the patient in AKI, based mainly on the appendance of experience, but not so much based on evidence. And there is some experimental suggestion that spironolactone may actually stop the progression of acute kidney injury to CKD. Thank you.
Thank you, Dr. Sunil Karan. Very nice lecture. Any question, answer from audience? You can ask. Okay.
Acute decompensated heart failure, is the timing of diuretics of any relevance? What I mean is that should you prefer to start with other modalities like non-invasive ventilation, progress to nitrates and then?
Yeah, see, as I told you, all these that we're talking about are all supportive modalities. So I don't think ventilator has anything to do with giving diuretics. Of course, decongesting the system is probably the first step of trying to address the underlying problem. But if the patient requires a ventilator, he would get the ventilator first, or non-invasive ventilator, he will obviously get the NIV first. That will be more based on the respiratory parameters rather than on the use of diuretics or not. Now, when you say about timing, whenever the patient comes to you with acute decompensation, certainly you would consider giving them one big slug of diuretics, of course. Other modalities, yes, we do start because as I mentioned to you, diuretics is only what we are dealing is the tip of the iceberg and the final common effect of what it is. So we are only trying to empty the extra fluid which is there, and cause some natriuresis. But why this process is happening is something which we have to address through other mechanisms, whatever it is.
Okay. Thank you, Dr. Sunil. Now I am inviting Dr. A.K. Singh for his talk on how to I select adequate analgesic in my practice.
Good afternoon to you all. My first visit to Namoland. Thank you, Rajesh, and congratulations for organizing the event nicely. I hope the session goes painless and the end is also painless. So let's start this session. How do I manage pain, either in the OPD, ER, or in the ICU? How many in the audience are pediatricians? None? Good. I will not discuss pediatric choices for drugs. How many in the audience are oncologists? Good. I will not discuss cancer pain. So we can restrict ourselves to some of the areas. Only two types of pain. One that hurts you, and second, one that changes you. It's really what matters in terms of pain management. Consider the fifth vital sign after respiratory rate, heart rate, blood pressure, and other things. Fifth vital sign gives you importance, that you need to give importance to pain as a paradigm of your management. Pain types, acute, chronic, and then further nociceptive, neuropathic, visceral, or mixed. There are whole categories of pain, acute and chronic. So my talk will be more restricted towards acute management as well as chronic management of pain. Acute and chronic defined per se by presence of a tissue injury and whether it is lasting for less than 1 month. Then that is acute. One that lasts for more than 3 to 6 months and is not associated with any injury, but there is pain beyond the expected period of healing is considered a chronic pain. And pain changes you, as I told you, it does change you. And chronic pain changes you even further. Why? Because there is a whole paradigm of things that are happening around pain, apart from the pain issues. Your cognitive changes, your impoverished mood, your depression, anger, anxiety, all are aspects of pain when they do not get tackled at the right time and the pain persists further on. Pain pathway, you start from the injury from 1, then you move on to the spinal cord as the receptor moves up, go up to the spinal cord and to this brain stem, and then point 4 is the cerebrum where it is actually perceived. This is the actual pain pathway, and so the paradigm of treatment possibly lies at 1, 2, 3, and 4. If I try and tackle 1, 2, 3, and 4, probably my pain management will be adequate. You may be working in the OPD, you may be working in the ER or in the ICU, in a primary center or in a tertiary center, so your choices may be limited. You may have an acute pain service, you may have PCAs, you may have epidurals, you may have regional anesthesia blocks, you may have spinal stimulators, you may have dermal patches fentanyl or buccal fentanyl. You may have a lot of choices depending on where you work, but since this session is limited to OPDs, ERs, and some segment to ICU, I'll try and limit my talk to these 3 areas. No matter where you work, you got to assess pain. If you don't assess pain, what is the reason? How are you going to decide whether your treatment is really working or not? So you've got to assess pain. These are some of the most classical ways of assessing pain: the Wong-Baker facial grimacing scale, the activity tolerance scale, and the verbal descriptive scale. These are some of the things that need to be done when you are trying to assess pain. What and where? As I told you, there is a whole choice of drugs which can be done and used when you try and tackle pain. So let's start from the first one, the noxious stimuli. You have choices like NSAIDs or COX-2 inhibitors. You have local anesthetics at that size. Then you can impair the transduction of this pain by using either an epidural or an intrathecal local anesthetics. You can modulate pain further on at the level of the spinal cord by using alpha-2 agonists, local anesthetics at that particular area. Then you can further on use epidural opioids, subarachnoid opioids. You can use ketamine if nothing works, or further on. And then you can act somewhere on the cerebral cortex by use of alpha-2 agonists, COX-2 inhibitors, paracetamol, ketamine, gabapentin, the list goes on and on. But for this session, we'll try and limit to 2 main areas. 1, the opioids, and 2, the NSAIDs and the COX-2 inhibitors. Analgesics, as we know, they can act either centrally or they act peripherally. Centrally acting will be the opioids, narcotic and morphine-like drugs, and peripherally will be the non-opioids or the NSAIDs, and the non-narcotic like aspirin and other drugs. In terms of NSAIDs, most of us do understand this pathway, that when there is tissue injury, phospholipids are getting released, there is arachidonic acid-related metabolism, which leads to further prostaglandin, and then there are 2 pathways, the COX-1 and the COX-2. So when we give NSAIDs, we try and block this. So an NSAID can be either a non-selective, which will block both COX-1 and COX-2, or it can be a COX-2 selective NSAID, which blocks only one pathway. So I block one, I'll either have an enhanced effect of the other, or I block both and reduce the pain as such. But there will be more related issues with it in terms of toxicity if I try and block one, which I'll enumerate as we go on. NSAID selectivity. 2 extremes. One, they're non-selective, absolutely non-selective like aspirin. Irreversible non-selective NSAIDs, cardioprotective at low doses, we all know this. But there is increased risk of GI side effects. Then we move on to the semi-selective and the non-selective mid-zone, the Brufen and the naproxen, which are again non-selective NSAIDs, decreased risk of cardiovascular, and there is increased GI side effects. So I'm trying and deliberately be slow on these issues because this is what will actually make your NSAID prescription writing correct. And then the semi-selective group, which includes a whole lot like meloxicam, diclofenac, etodolac, indomethacin, paroxicam, and Sulindac, which are all semi-selective NSAIDs with increased affinity for COX-2, but still retain some activity for COX-1. And then the last one, the more dangerous one, are the COX-2, highly COX-2 selective with increased risk of cardiovascular toxicity and events and decreased risk for GI side effects. So they are good for GI, but they're bad for the heart. So this is important to remember when I use a COX-2 selective group. Classification, don't go into numbers, I'll just point out the most important. Brufen, for instance, these are non-selective, the clock is taking away that area. So it's non-selective, if you see the half-life is 2, so it's pretty fastly acting, so can be used for acute pain relief as a wonderful drug. Naproxen, see the half-life is 12 to 17 hours, so the timing, how many times I want to give it in one day will be decided based on this half-life. And second aspect is bioavailability. Can I give it orally? Will it get absorbed very fast? That is important for me to know. So the more bioavailable it is, the better it is for oral medication, I can use that. Ceiling effect. Remember, all anti-inflammatory and NSAID drugs will have a ceiling effect. That is, Brufen has a ceiling effect at 400. So if I want to give 800 for a patient, it may not give me the actual effect. It may rather produce more toxic effect. So 400 will give me the equal analgesic effect as an 800 milligram will do. So why do I want to use 800? Why I'm not happy with 400? Because at 800, I'll have more toxic effect. So it is important that when you give a drug in the form of NSAID, you know how much is the ceiling effect, how much will be advantageous, and beyond which the advantage goes away. So these are the group and the dosing patterns which are in terms of ceiling effects. What is the most effective NSAID? I don't know the answer to this. What is the most effective? Is naproxen better? Is other drugs better? Somebody tried and did do this analysis by the Oxford League table. Now what they are trying to do is they are taking use of NSAIDs in different practice zones. Like there may be a dental extraction pain, there may be post-operative pain, there may be a low back pain, there may be a simple pain. So they try and do this Oxford League table analysis, and then they try and put an NNT number onto that. That is, if there are two patients, if I give an NSAID, and within the next 4 to 6 hours, if 50% pain has reduced or not, one, and if among the both two, how many will say, okay, more than 50% pain has reduced. So the lower the NNT, the better the drug, according to this Oxford League table. The lower the NNT, the better the drug. So if you try and look into ibuprofen, the NNT is 2.4, and which is a relatively very good drug for pain relief. And the other ones are naproxen, which is around 3. Any drug with an NNT which is on the higher side is not considered as a great drug. If you have to reduce the NNT numbers, if it is on a higher side, say for codeine, it is around 16, then you probably combine it with an acetaminophen, then the NNT number reaches somewhere around 3.9. So the lower the NNT, the better the drug. And as I told you, the risk factor, the more you go towards cardiovascular, the more dangerous it is, or the COX-2 selective, the more dangerous it is. Temporal relationships, we must understand the toxic effects of some of these drugs, like GI events, nausea, vomiting, dyspepsia, gastric ulceration, GI bleeds, cardiovascular events in terms of myocardial infarction, stroke, angina, heart failure, and hypertension, renal events, salt and water retention, interstitial nephritis, nephrotic syndrome, acute renal failure, and acute tubular necrosis. No matter where the studies are coming from and how many studies over an extended period of time, all these will be observed. So how many of us do realize when we write an NSAID, are we looking into some of these aspects? So got to understand that all of these drugs will have these effects. And the longer it is used, the higher it is used, the more potential will it have for toxicity. In terms of GI, clinically significant upper GI reported in almost 2%. These are US data. In almost 2% of patients who were prescribing this drug, GI complications had no prior symptoms. This is again dangerous. You will not have a symptom, yet you can have a toxicity of this drug. GI hemorrhages due to NSAID will result in almost 1.2 lakh hospital admissions in 1 year and resulted in almost 17,000 deaths of NSAID-related GI toxicity effects. COX-2 selective. So if I say a non-selective NSAID, suppose I don't want to use COX-2 because it is cardiotoxic, can I use COX-1? So amongst all the COX-1, I would say ibuprofen is still much better than all the non-selective cardiotoxic effects, because if you see, it's just around 1, the cohort study. This is reported. It is relatively safe even for the GI, for the GI-related complications, much safe for GI. Temporal relationship, again, systematic review. Risk was greatest in current users who were using the drug, and the GI events usually occurred within the first 30 days of starting this drug, and the risk remained constant over the next 12 months of this period, and it subsided after 2 months of stopping this drug. So what are the risk factors for GI? Age above 65, patients who already have a peptic ulcer disease, who are using concomitantly drugs like steroids, who are using aspirin, who are using anticoagulants, If any of your patient is using any of these drugs together, your NSAID will not have that great effect and will have more GI related toxicity. And if you see the terms of death, if you see the deaths with compared with acetaminophen, see the deaths with all analgesics, see the deaths with opioids, and see the deaths with NSAIDs. NSAIDs will, the number of deaths with NSAIDs is far more. These are US data. Indian data is not available. So these are US data. If you see the death rate with NSAID is maximum, relative with opioids and relative even with acetaminophen. So you must be cautious when you're writing an NSAID as a prescription of choice for your patients. Now, why the cardiovascular toxicity is so high, as I told you, when you try and block one, the other gets over accentuated. This is the prostanoid hypothesis. This is one of the reasons which they say is responsible for why the COX-2 selective drugs are leading to more of toxicity. And most favorable cardiovascular risk profile will be with naproxen. If you want to use naproxen and low dose ibuprofen are relatively much better. Elevation of cardiovascular risk is noticed even with low doses of diclofenac, unlike drugs, and the high risk of cardiovascular disease is strengthened warnings. FDA has recommended for strengthened warnings against use of Brufen above 1200 milligram patients if there is a risk factor for cardiovascular